The next speaker is Rajesh, who will be talking about what COVID has done to the residency program training.
I invite Dr. Rajesh and he will speak on the postgraduate training in the COVID era. Dr. Rajesh.
Thank you, sir. Thank you. Thanks a lot. It's a matter of great honor that, I'm sharing the dais with people like Dr. Lahane and Dr. Mohan Rajan, who have done so much during this COVID era. I must say, Dr. Mohan Rajan, you are like Sonu Sood of Chennai. And I was not aware what all you have done. And
nothing when compared to Lahane, sir. He has done for the state.
No. Both Dr. Lahane, sir, and both of you have done so much that, it's really, that's why I said that it's a matter of great honor sharing dais with you people. I'll be talking about postgraduate training in COVID era. Now, before COVID era, we had a normal life, you can say, a normal teaching system wherein we had a physical classroom teaching, wherein, all the students used to sit. We had a proper, didactic lectures, and there was, face-to-face interaction, and that could increase the understanding of the subject. Then again, regarding clinical exposure, patients were there. A lot of patients were there in the OPD. A lot of patients were there in the ward, and bedside teaching was done very nicely. And bedside teaching is the best thing for a clinician. And that was really, that was something which was very useful for the residents. Then, of course, the surgical training, the more you do, the more you learn. And the more you teach, the more you learn as well. But as far as residents are concerned, over the last 1.5 years, things have not been the same. Earlier, there were so many cases, and by doing cases and by getting assisted by their senior, senior colleagues, it was a great learning experience for them. And even for theses and projects, which they were doing, there were enough cases to fulfill the mandate. But as COVID-19 came, as this pandemic came, everything got stuck. Everything got affected. Like for theoretical knowledge, initially there was a lockdown, so there was no class, there was nothing. People were in a state of shock. They just could not think of anything. There was no face-to-face interaction, and a lot of teaching in terms of lectures got affected. There were no patients. The hospital was mostly used for COVID. So there was no patient coming for ophthalmic checkup. Patients were, all in-house. Nobody was moving out. No bedside teaching was done. No skill transfer. No patient being operated. So the surgeons, the residents were not getting any training. And the thesis project also got completely shut down. There was negligible meeting as far as ethics clearance is concerned. No ethics clearance. Then whatever data was there, they were not getting the data. So even the thesis projects, these all things got affected very badly with impact of COVID-19. And then the biggest problem was this, that in a multi-specialty hospital, what happened, like something like ours, what happened that about 70 to 80% of residents and the faculty were posted in the COVID wards. So ophthalmologists leaving all the ophthalmic work and working in the COVID ward, trying to learn from the physicians how to handle, trying to learn from the anesthetists, from intensivists, how to handle these patients, what to explain to their relatives. And so this was all affecting very badly as far as the ophthalmic training is concerned. And even at that time, there was a decision in some states by the government to extend the residency period, but that was also to take up the COVID duty. So these all things were affecting not only the training of the residents, but it was affecting them very badly in terms of their mental health as well. So a lot of new things came up. We all know that, with time and with problems, we try to innovate new things. We try to get back to new things. And then virtual platforms came in. So there are certain queries. I was just, when I was given this topic, I just spoke to a couple of my residents that can you just message me a few queries that you think during this period? Because we are having this online training, we are having this, all these things. So what are the queries in your mind? So these are some of the queries that they gave, that can virtual platforms replace the physical mode of theoretical and clinical knowledge transfer? Well, I guess no, they cannot replace. But yes, they can be of some help now and in future. Does wet lab give a real-time experience? Like we keep telling our residents that you should go to wet lab, you should try to learn in wet lab. But they said that does wet lab give a real-time experience operating on a patient? Our ophthalmologists who are getting the degree in this period are confident enough in clinical knowledge and confident to do surgeries in patients? And how to fill the gap of learning curve? Does more time suffice? When will we return to pre-COVID training, which I guess nobody knows? And are our young ophthalmologists trained enough to treat patients? And all these queries, part of which we can answer, but part of which is still not answerable. So what should we do now? Well, we have to develop online teaching to minimize disruption to student learning, and that is what we are doing. The virtual platforms are there to tell them what exactly is ophthalmology, to give them the theoretical knowledge, to give them the knowledge about patients. And there are so many webinars in this direction, and you can see the residents attending the webinars. Most of our residents, they keep telling that, yes, I attended that webinar, I attended that, because our own classroom teaching has got affected. Plus, in addition to that, apart from the webinars, we are also doing our online classes of our own group of residents. Like the center is divided into different units, so we are having the online classes. So on virtual platform, we are doing it. Then you can also show the videos of clinical methods, that how to examine the patient. One can create videos of slit lamp biomicroscopy. One can create videos of, indirect ophthalmoscopy, etc., 90D examination, etc., and show to the residents virtually. You can take videos, unedited videos, and then show to them that at what step, how to control, if you are doing a rhexis, if it's running out, how you have to control it. So these things can be done. And of course, the residents these days are well versed with the online system, so they can catch up quite fast. Then the other thing is that you can have a recording of that, so they can attend at any comfortable time. So there's nothing that they have to be there all the time. Then there is another advantage that, there are faculty from across the globe who are taking classes, and then it also allows more and more members to join in, to participate. As far as skill transfer is concerned, as I was mentioning, we can do teaching on unedited videos, which we are doing these days. We are asking for unedited videos of current residents or even the past residents, or some of our own unedited videos wherein we have landed in trouble. So we can train them that these are the things that at this stage you have to control things so that you can learn. Then on go-tie, initially there was a problem in getting the go-tie when there was a lockdown and there was a fear of transmission, but later on we started getting go-tie. So on go-tie, every hospital can make wet lab. Wet lab can be established in every hospital. You just need a small room with a microscope, which may not be a very high quality, but it should have a video connection so that the trainer, the person who is training, who can see that what mistake the resident is doing. And then you can have a go-tie and a stand to put on it. And then, of course, machine, whatever you want to train, like FICO machine or SICS thing or whatever you want to train. Then simulators are a bit costly, but simulators are quite effective in training the residents, because it improves the hand-eye coordination. And that is what is needed very much in microsurgery like ophthalmic surgery. Then it is always better to involve residents in teleconsultation, because in teleconsultation, the patient will tell about their symptoms. So so it will be like an OPD. You're sitting in the OPD. You may not be able to examine thoroughly the patient, but you can have an idea of the differential diagnosis, that with these symptoms, what all are the possibilities. And then, of course, the senior person's role comes, that he can give you an idea that with this we can, reduce down to, these many differential diagnoses. And this is, the surgical simulator that we have, and this is how it looks like. So when the residents, they do, say, suppose one is practicing rhexis, so at times it shows, suppose the hand is not moving properly, it shows how the rhexis is extending. So how you have to control it. So it gives you a good hand-eye coordination, and that is very much essential in a microsurgery like ophthalmic surgery. Goat eye is something, as I said, that you can, a lot of surgeries can be practiced on goat eye, and it may not replace a real patient, that is very true, which was one of the queries of our residents, but it can be of great use, because if somebody learns to do rhexis on goat eye, he will be very easily doing rhexis in human eye. This is based on my own experience, I can say, because doing rhexis in a goat eye is more difficult than doing rhexis in a human eye when one is practicing. So this is something which one can practice and one can learn. So in every hospital, such a facility can be installed with a very minimum cost. This is what graph of goat's eye, wherein the residents can practice. You can do a keratoplasty as well, put sutures, so hand-eye coordination can be done. So this is what is the new normal. You can later on use this teleophthalmology and the other things also as a part of follow-up of the patients. And the only thing I would like to add is that we will definitely get back to our new normal, but then these are the situations which teach us, and in future also we can use the virtual platform as well as teleconsultation as a part of training the residents. And regarding thesis topic, currently we should give topics related to retrospective analysis of data and small sample topics, etc., so that it can be completed fully. So we have to think out of the box in this situation. We have to plan as per the situation, and where there's a will, there is a way. We have to find out ways to train our residents. Thank you very much for your patient listening.
Really a fantastic talk, Rajesh. What I want to say is my sympathies to the postgraduates who are in this COVID era, seriously, because everything else they can learn. They can learn the theory classes because online classes are there.
Absolutely.
So many webinars are there, beautiful webinars are there. AIOC itself is conducting so many webinars. They're able to learn everything else. But for surgery, they need to do. So we need to either go to the goat eye, or probably simulators are the one of the way, but it's very costly.
Yeah.
The problem is very difficult to implement it in all the centers. Lagane sir, I want your opinion on this, sir.
I think what you are saying is very true, because for the residency, not only the ophthalmology, orthopedic surgery, then the gynecology, this plastic surgery, neurosurgery, then the cardiac surgery, everywhere I will tell you, there is a very, very big gap of 15 months. And those batches who were in the second year, I think they have not done it. The first year, they have not done anything. They have joined 15 months before. But till date, they are only in the, because they are junior and posted in the COVID ward. So that is the problem. So now what I'm telling, I have issued a circular to all the teachers that from the 15th of June, that the cases may be less, but all the cases should be used to teach all these people who are now going in the third year. And so the extensive teaching by the teachers, and I have also asked not only the SRs, but also the lecturers, assistant professors, associate professor, and professor, they should teach and submit with the report that what they have taught practically. I don't want much theory, because they all are tired of theory. Every day they are listening. So I want them practically what they have taught to them, not only the goat's eye. You can use goat's eye, yes, for the experience, but on the human eye, and they should now feel of the patient, how they can treat the patient. And we are basically admitting mature cataract to teach them in not only in my hospital, but all over Maharashtra. we are admitting the patients who are operating in the other eye, so that other eye can be operated, we will permit them. So that we are doing it not in one subject, all subject in Maharashtra, and we will make them feel that we have trained them properly in Maharashtra.
This is a wonderful idea, sir, that we should focus right now on the third year students more, so that, because they will be passing out very soon. So we should focus, whatever patients we get, we should focus on the third year students.
Yeah, another big problem, Rajesh and Laghane sir, is that because we all depend on the eye camps for getting the patients for the postgraduates for the training. And the eye camps, there are a lot of protocols now. We are not able to conduct eye camps. I'm talking about in state of Tamil Nadu. I'm not sure what is happening in Maharashtra, but
Everywhere.
But I'm just telling you, eye camps is a big problem, because even if we have eye camps, you can have only 50 or 100 people in that camp. We can't screen more people, and that is the reason why our workload, everything, even if after the lockdown is lifted, also the same problem is there. So we have to overcome this.
I will tell you.
Yes, sir.
What we did in Maharashtra, because see, we can't gather the gathering. So what we have done, we have got the ophthalmic officer, that is ophthalmic assistant. And that is under the national program. We have got 685 people working in Maharashtra. So we asked them to go to the house to house survey, and after survey diagnose the patient of cataract, diagnose patient of some diabetes or some problem, anything. But cataract we are diagnosing, and we are bringing the cases in the, you can say, the at big places in the bus. So in the bus we are bringing, only thing is that we are not bringing much relatives there. So in one bus, we are bringing near about 30 patients. That is a 45-seater. We are bringing 30 patients and operating. But here, no gathering. In the wards also, one cot is not, in one cot there is no patient, other cot there is patient. Otherwise, there is a distance of 2.5 foot we are keeping. So that is helping us, and that we are doing routinely now, not only on Saturday, Sunday, but also we are doing on the 2 or 3 days a week.
Very good, sir.
So I have a little suggestion to give. They say every pandemic has an opportunity. Don't you think the time has come to consider 3 things? Number one, that we should have a national level exam when people are paying for professional exams, so that the standard remains the same. We should have something like a need to pass out of MBBS, a need to pass out of first profession. Secondly, with Zoom available so freely, why can't we have national lectures, so that students studying in remote medical colleges, where the teaching may not be up to the mark, could access the talent from Bombay, from All India Institute, from PGI Chandigarh. So if they could give 2 hours every day for every specialty, so you can have across the board national talent. So, somebody like Dr. Lahani or Dr. Rajesh Sinha could address on a particular topic. Now, LBP does this for their own hospital. All India Institute does it for its own training, but they're all silos. If it comes at a national level, look at the dramatic change it will make in academic exchange. The third thing is, in terms of surgery, it has always fascinated me that in India, we need eye camp surgeries to learn surgery. But some of the smartest surgeons still in the world come from the United States, where there are no eye camps. Now, how did a gimbal discover capsulorhexis? How did a Harvard Fine discover the steps of phaco? These people do not have poor man's eyes to that extent. They have veterans hospitals. But how is it with limited number of surgeries they're able to accept? So that is something which we have to realize, that mass surgery does not mean quality surgery.
I think what Dr. Sethi was telling is very true. That what we have done is, I know we are doing out the video conferencing, and what we have done is we have made a lectures, not all over, but we have made out of 19 medical colleges of government of Maharashtra. Up till now, we have covered 12 medical colleges where we have got the virtual lecture halls. They are sitting there. They can ask the question in the real time, and we can discuss this. That we have started. And we have made a PHM department of the government of Maharashtra, that is JJ Hospital, is a virtual classroom. And I will tell you, this virtual classroom is a very good classroom where we can teach the people outside, and they are sitting in the lecture hall. So that we have started in 4 medical colleges. Now we are doing it, but it is also helped by the government of India. It is the scheme of the government of India under the, I think, elderly people. So from that, they have given us some money, and we are doing it.